Well, good morning, everybody. We still have a few more minutes before the day goes to afternoon. Thank you for joining us. And it has been an exciting morning, and it is running over time in the plenaries. And we are now here to talk about the pandemic response and initiatives. And we are going to have it in two parts. The first part is by Dr. Michael Farku. Can you move on to the next slide, please? He will be speaking on the chronic conditions and mental health. And then followed by that, I'll take over the discussions for about 10-15 minutes. Then we will move on to Dr. Murthy to talk about the modeling and preparedness. Mike, Dr. Farku is the chair of multinational clinical trial, and he's a cardiologist and professor at University of Toronto. Mike, it's a pleasure to have you. Please carry on.
Thank you, Arun. It's a great pleasure to be here amongst colleagues and to summarize what has been discussed in our panel. I'd like to begin by just saying that this pandemic has put stress on our system that is unprecedented. Next slide. I'd like to acknowledge our panelists, Dr. Dennis Koh, cardiologist in Toronto, Dr. Avro Roy from India, who has been involved in the mental health impacts, Ms. Arti Basan from Canada on addictions and substance use, and Dr. Indira Karana, who is an expert in pain and low-level laser therapy here in Toronto. Next. Well, cardiovascular conditions have been impacted by the pandemic, and what we have seen is something very interesting. If you look at the trends in the right-hand graphic, you'll see that there's a reduction in the patients presenting with an acute heart attack or acute myocardial infarction in the COVID era, reductions of about 25%, which indicate that either heart attacks are actually going down or people may not be seeking care in the COVID-19 era. So we've seen some interesting impact on our practice. Next. Well, there are a number of reasons for reduced hospitalizations for cardiovascular indications. One is public health interventions. This would, of course, have longer term implications, but social distancing, taking better care of yourself may actually improve outcomes even in the short term. There's the fear of hospitals. Patients are fearful to go to a hospital for maybe contracting COVID-19. There's reduction of illness due to physical activities and stress. When people are at home relaxing, hopefully taking it easy, they may not push themselves to the point of having an event. And then, of course, there's decreased capacity to care for these patients with routine medical problems because they may have COVID illness overwhelming the system, and non-COVID illness may be sidelined. Of course, in acute heart attack, we hope that would not be the case. Next. Now, for patients with hypertension, which is a major risk factor for complications of COVID, the monitoring of blood pressure has changed. Pre-COVID, people would go to their GP's office, their doctor's, cardiologist's office, pharmacy, home devices. In COVID, it's gone to home monitoring, which I think is an advance. The other thing is medications that we use for hypertension have been associated with some complications of COVID, ACE inhibitors and ARBs, the drugs that end in sartan, these are the ARBs, or the Pril drugs that end in with ACE inhibitors, have been implicated. I guess they've been now cleared as far as complicating COVID, but there's some questions about how we manage blood pressure in the COVID era. Next. And finally, when you hospitalize patients who are hypertensive, we see some evidence for increased risk of severe infection in patients with hypertension, to keep an eye on them. And then, of course, there's uncontrolled hypertension in acute cardiovascular events because patients may not be taking their medications or being followed closely enough. So these all have implications on our healthcare system. Next. So we've formed multidisciplinary healthcare teams to help us address some of our vulnerable patients. They include patients with suspected or established hypertension, older patients, medically underserved patients, high-risk patients, patients with multiple comorbidities, patients with who are isolated due to the pandemic. And we have multiple new and maybe better systems in place now to form these multidisciplinary teams, telemonitoring of vital signs, medical tracking, educating people about lifestyle, and video consultation have all been advances that have kept us in touch with our patients. Next. So in summary, for cardiovascular conditions and COVID-19, as presented by Dr. Dennis Koh, the damage is that COVID-19 poses an indirect damage to the healthcare system, as we've talked about. How could we deliver public health messages for the future for social lockdown without causing care avoidance? This is very important. Significant data lags made it difficult to rapidly adopt policy changes. And we know that there are vulnerable populations disparities, socioeconomic disparities, that for patients to have equal access to telemedicine, virtual care, and the ability for self-care. Now we'll move on to our next session. Next, mental health impacts of COVID-19. Dr. Roy summarized this beautifully. There is the issue of depression, anxiety, and burnout in healthcare workers. The rates are as high as 64% during COVID. With risk, those at risk are those that are younger, single, female, frontline workers, and nurses. They all have a higher likelihood of burnout. These are the people we rely on in our health system. We must look at compassion fatigue as an issue as well. High levels of anxiety on availability of protective devices and masks and so on, and patient care equipment. This causes distress due to severely ill patients and families unable to meet or communicate. So we have a lag in the system which stresses us in terms of compassion. And then there's the stigma. Healthcare worker stigma is an independent risk factor for increased rates of alcohol use disorder.
Yes,
This is an important issue.
I think there's a dead animal in our.
Someone can mute, please. Next. Now, we do have some mitigation strategies that are institutional, corporate, and governmental. And we have put these into place so that we can address the mental health impacts. We may be living with this for many years to come with regards to the impact on young people and people maintaining a normal life, particularly on a mental health basis. Next. Now, we've also looked, RT looked into the addictions and substance use in COVID-19. Poor mental health increases substance abuse, and addictions thrive on isolation, and people are isolated in this current era, as we are now. Next. And you'll see here that alcohol use has increased 20% there's a 20% increase in alcohol use, or 20% of Canadians have increased their alcohol consumption, is probably a better way to express it, due to stress, boredom, and lack of a regular schedule. And the Canadian retailers have seen a massive surge in alcohol sales during the pandemic. Next. We've also seen in India, in Bangalore, the initial lockdown, closure of liquor stores caused alcohol withdrawal syndrome. And you can see here in the shaded area in this graphic that during the lockdown of 22nd of March to April 3rd in Bangalore, you see there was a tremendous surge in alcohol withdrawal syndrome because of lack of accessibility to alcohol in patients who are dependent on it. Next. And finally, in Ontario, we've seen an increase in the deaths by accidental deaths, which we think may be related to the opioid crisis. This is a crisis that was existing before we had COVID-19, and the increase in opioid-related deaths in Ontario during the first lockdown was established. And this is very concerning because patients may become more dependent on these narcotic medications. Next. So moving forward, we need access to resources for our patients. We need to reduce stigma, both of mental illness and addiction. And we have to understand the effects of lockdown and whether we should actually be locking down to the extent that we have. This needs to be evaluated. Finally, we're going to go to the chronic pain segment of our presentation. Dr. Khurana's work on chronic pain syndromes. Next. You'll see here that low-level laser therapy to affected areas that are related to muscle pain related to COVID can be treated with local low-level laser therapy. Unlike systemic therapy like steroids, it does not cause effects on virus elimination, secondary infections. It actually may, in fact, help us counteract the inflammatory responses of COVID-19, the cytokine storm, which causes the deterioration in patients in requiring ICU care. Next. You can see here, this is a graphic that underlies how the virus leads to pulmonary and endothelial damage of the vessels, and then to what happens in about the first week. In some patients, a cytokine storm, an inflammatory storm, which leads to clinical deterioration, which is sudden and dramatic. And it may be that some of this local therapy affects this trigger of cytokine storm. We just don't know, but it is a theory. Next. So laser therapy that's low level can be carried out in sessions of 20 to 60 minutes. You can do 6 to 10 sessions or more, or 10 to 20 if it's more severe symptoms of muscle pain. And it's been effective in about 80% of patients, which is very promising. Next. Well, that's our presentation of our panel. And I'm going to open it up for discussion now. Hand it back to Dr. Chakalingo.
Are you able to hear me?
Yes.
Yeah, I don't know why my video is not coming, but that's okay. I am delighted some of our panelists are here. Dr. Dennis Ko, Dr. Indira Khurana, and Dr. Michael Farku, and Aarti are here. Brilliant presentation, Mike. You have summarized very well. Let me ask a question to Dennis. Dennis, you showed that there is a decline in the number of people admitted to the hospitals for cardiovascular disease. And that's very well shown on that graph. But has that continues or is it going back now?
Yeah, it's a good question, Arun. That I think that during the initial phase of the pandemic, we saw heart attack that goes down, which is usually not the case. It's usually quite stable, but we also saw a kind of reduction of hospitalization and many other conditions that, except for childbirth, really, you have a reduction of like CHF, even appendicitis, COPD. I suspect that clinically that, these things very sensitive to the public health message. So anecdotally, we saw that there was rising number of admission, after the first wave, and things seems to be back to normal. We track our number for STEMI, which is the acute heart attack. The third wave, when there were like a lot of publicity about the third wave, lockdown again, I think that actually has direct impact of the number of people going to hospital, but it's not as bad as the initial wave because people are scared, people are just kind of staying in hospital. So I really think that the public health message has been, with the lockdown, really had impacted this this problem, and it's kind of up and down, but it's not as bad as before, is what my feeling is.
Thank you, Dennis. As a follow-up question, if most often people who have coronavirus, they say people died out of sudden heart attack or sudden cardiac arrest. What does it mean? So that means it is affecting the organs?
Yeah, I think that's a good question. Like, during the pandemic, we also saw a reduction of people calling for 911 and calling for cardiac arrest. And so there was a lot of concern about whether people are dying at home. And I think it's probably multifactorial. I think there are, our encounter with people with COVID-19 is that they could be quite hypoxic and they feel well and people deteriorate very rapidly. So we have these COVID type of program from the hospital, and we've seen these patients in the hospital. you have a young person who looks fine, and the SAT could be 80%, and they arrest and they have respiratory decompensation very easily. And I suspect some of those are, patients are at home. And I think that's probably the most likely. And obviously, there have been reports that COVID-19 impacts the cardiovascular system, causing heart attack. And we've seen a lot of those patients as well. So I would suspect it's probably multifactorial, but I think the hypoxia and the respiratory impact is probably greater than the cardiovascular.
Thank you, Dennis. Dr. Kurana, from the pain perspective, because you have clearly shown that the laser therapy really works, and how long does it take to get somebody who is suffering from post-COVID situation and when they're recovering, and how long the treatment is required? You are muted. Please take off the mute.
Can you hear me now?
Yeah, yeah.
Okay, so basically when a person is out of ICU or even with the mild COVID symptoms, they do get a lot of fatigue, so that is muscles are going weak. So depending upon the damage, sometimes, even 5 to 6 sessions are good enough, or sometimes you have to do 10 or more sessions. And depending upon the area, sometimes we have to treat only for half an hour or it's 1 hour session.
Thank you. Dr. Farku, you're a practicing cardiologist. So the effect of COVID on the chronic diseases and the effect of chronic diseases on COVID patients. So can you shed some light on that, please?
Well, we know that patients with diabetes, obesity, advanced age, and hypertension are all risk factor for complications of COVID. And so that we need to follow these patients closely, be very, very careful, make sure they're vaccinated as soon as possible, and to make sure that they mitigate all of their activities, masking and the social distancing. Now, the other side of it is, that a lot of patients continue to be at risk for stroke, heart attack, cancer, and other medical conditions. And we cannot stop the surveillance of this. And how we do this has been challenging with virtual platforms, because it's hard to examine the patient or do a stress test or a colonoscopy or whatever. And so it's important that we, I think, understand that we have to delay some of these procedures, preventive procedures, but we need to really ramp it up in the post-COVID era as we head into the fall in the next several months. We've got to make the time up, and that means we're going to have stress on our system. So it's a two-way street, right? One is, the good news is that, these aren't urgent situations, but the problem is COVID complications are related to these chronic conditions. The care of patients for these chronic conditions has been impacted. And finally, we have post-COVID syndrome, which will also, we'll learn a lot from what's going to happen 4 or 5 years down the road to these patients who had COVID. Very important not to contract COVID, very important to prevent its complications.
Well, thank you very much, Dr. Farku, on that. Now, we have got 2 eminent cardiologists in the panel right now. Now, we keep hearing from India now that a number of people who have taken 2 doses of vaccines are still affected by COVID again, and then they die instantly. Any thoughts, anything that you can suggest why it could be?
Dennis, I'll let you start.
Yeah. Dennis?
Yeah, so I don't honestly, I don't know enough about it. I think there is, really discussion that, even if you've got 2, the initial thought about this COVID vaccine is that, it reduces, it reduces severe hospitalization, severe illness, and, the rates is almost 100%. But, with the number of variants and such like that, I suspect it's not foolproof, but I don't know enough about it because we don't have a lot of experiences here. Like 2% only, like less than 5% had 2 doses of vaccine, and we've never seen that in Canada. So I've heard a lot about those kind of news clippings, but I don't know enough about it.
Mike, any thoughts?
Nothing more to add. I mean, I think I agree with Dennis. I mean, we just need to learn more.
All right. Now coming to Aarti, you are working on depression and people taking up substances, and you showed in your graphs that people are having withdrawal syndromes and getting addicted. And is that addiction a short period, or is it continuing as the COVID waves are going up and up?
Thank you, Dr. Chokalingam. So the graphs presented by Dr. Farco earlier are mostly from the first wave in both Ontario and in India. We are waiting for peer-reviewed data on the second waves, both that's ongoing in India and the second and third waves that have occurred here in the province of Ontario. However, from the qualitative work, it does seem like these issues are persisting at similar rates, at least here in Canada. I did see an updated report from federal regulators commenting on how still in the second wave, it was estimated that about 20% of surveyed Canadians were still commenting that they were increasing their alcohol consumption, again, due to level issues of boredom and isolation. So it's very interesting. It's important to look at because I think this lockdown has definitely been a catch-22 in some sense, where we've had to isolate to help curb the spread of COVID-19. However, while doing so, as Dr. Farco highlighted, you're highlighting these issues that are very much related to substance use or increased consumption of certain substances, which are boredom and isolation. And those with existing addiction-related issues, again, being isolated, they don't have as much access to their support groups, which is a huge part of the recovery and relief model. So we are waiting for peer-reviewed data that's more recent, but it seems to be from qualitative work that it's persisting.
I'm not sure I see, thank you very much, Aarti. I'm not sure I see Dr. Gabriel Roy. Is he here or has he to leave? Because he being an emergency physician must have got a call, must have gone. The question is, the people in the front line, they get PTSD, and there are much more deaths of the frontline workers. And perhaps I can ask Dr. Thakur, who is a public health expert, and he's in the panel here. Dr. Thakur.
Yes, so the people who are in the front line, they are more vulnerable. And in fact, from India, we have, reports which are, you might have seen that the immediate past president of the Indian Medical Association, who was an eminent cardiologist, Dr. K.K. Agarwal, he died. And we also lost some of the people. So the people who are in the front line, they are vulnerable. And the problem is that now the institution where I work also, the infection rate among the healthcare worker is quite high. And the reason for this is that many patients who are coming to the bigger institution like ours, many of them are also positive. So despite taking all precautions, so this is a big problem.
Thank you, Dr. Thakur. There is a question here. Oh, go ahead, Aarti.
Sorry, just to add briefly on the issues of PTSD and healthcare workers, at least here in Ontario and in Canada. I'm not well versed about the stats, but I do know that it is on the radar. And Minister Michael Tabelli earlier in the keynote session was commenting on how it is on the government agenda to provide services and more structured services for PTSD and for frontline workers. So I really do hope to see that notion be carried through and also extend to different areas of the world because it's very important.
Thank you very much, Aarti, for that insight. There is a question from the floor. Is it safe to treat multiple corona positive patients in same room? What are the chances in increment of cross infection when we are witnessing multiple variant patients at the same time. Anybody wants to venture? Otherwise, maybe I'll ask Dr. Thakur to respond, who is also on the front line. Dr. Thakur, what is you?
Okay, so let me just go through. Yes, so I mean, in a country like India, where we have a large population, so here we are following the standard operating procedures, but at the same time, multiple patients are being treated in the same room. Of course, there is appropriate distance which is maintained as per the guidelines, and there could be chances of cross infection. But as of now, from the surveillance which we have got in my institute, because this is the second largest medical institution in the country, we have not come across of this type of cross infection, because we have quite active infection control committee in the institute. But we cannot rule it out, because it is quite possible that there may be chances of infection in India, because some of the hospitals are really overcrowded with the patient, and we are not able to maintain the required distance between the patients.
Thank you, Dr. Thakur. Any questions from the panelists among yourselves, or otherwise we can move on to the next session? If nothing, I want to thank all of you for your great contributions. So let's move on to the second panel. And Dr. Kumar Murthy will present on modeling pandemics and vaccine and equity issues. Dr. Murthy.
Thank you, Arun, and thank you, everybody. We have a lot to discuss here, and we're in a very serious situation worldwide. These topics are not easy ones to cover, so I'll try my best to summarize the conversations that we've had amongst the panel. If I could see the next slide, I will show you the panelists. Dr. Ron Dembo is CEO and founder of a company called Risk Thinking AI, which introduces an AI-based approach to analyzing risk, and he's applied those methods to analyzing the pandemic. Dr. Brian Schwartz is Vice President of Public Health Ontario and co-chair of the Science Advisory Table. Dr. J.S. Thakur is a professor in the School of Community Medicine and Public Health in Chandigarh, India, and an advisor to the Indian government. And I'm a professor of mathematics at the University of Toronto, director of the Fields Institute, and co-chair of the Modeling Consensus Table. Next slide, please. So in trying to understand, give useful information on what direction the pandemic is heading, modeling is obviously an important tool, especially mathematical modeling. There are a large number of models, different kinds of models. The most traditional ones are the family called compartmental models. But as an illustration of what's happening during this pandemic, of new science even being created, in Toronto, we've been evolving a new model, which we call Hurricane, which tries to take lessons from how we predict meteorological events or the path of a hurricane to see what we can say about the path of the pandemic. Here's a slide indicating the situation in Ontario. What we're plotting here is not just the number of daily cases, which is what you normally see on an epi curve, but how quickly those numbers are changing. So we call it growth versus acceleration. That's what we're using as a proxy for, in the case of a real hurricane, you would use latitude and longitude to mark the position. So we're plotting growth versus acceleration. And on the graph on the right-hand side, you can see how during the course of the pandemic, this growth and acceleration have been going around almost in a cyclical way. And right now we are in a reasonably improving situation in the lower left quadrant. And the model predicts one of two possible scenarios for how we will go forward. And obviously we hope it'll be the better scenario of the two. Okay, next slide, please. This slide shows Ontario relative to other provinces on a recent date, May 16th, a couple of days ago. You can see that as of last week, Manitoba is an outlier. It's kind of worrisome to see the movement of the Atlantic provinces. You see Newfoundland and Labrador showing significant acceleration, as well as Prince Edward Island starting to move towards positive acceleration. So we can see these movements in time as well. I don't think we we have the time to show you, but we have actually two short movies to illustrate dynamically how these change. I think for the time being, we will skip that, and if there is time, we will come back to it. Next slide, please. Here is a slide that was provided by Ron Dembo. It shows that the pandemic considers the fact that the pandemic is not only a health issue, but affects many other aspects of society, especially the economic aspects. This tool that his company has developed helps one to understand the trade-offs between epidemiological-based outcomes and economic impacts under different lockdown regimes and compliance scenarios for COVID-19. The risk factors in this case are compliance with mask wearing, hand washing, physical distancing, and hygiene. And there's an algorithm that coordinates between an epidemiological model to understand health impacts and an economic model to understand economic impacts. The data feeding this model comes from publicly available sources. And the development of such a model is, of course, a highly interdisciplinary piece of work. And we will if there's time, we will come back to discuss that further. But one interesting thing Ron likes to point out that in his study, he believes the conclusion is that lockdown is a very blunt instrument that is not as effective at managing the spread of the pandemic as compliance with mask wearing and other public health measures. So something that we need to discuss further. Next slide, please. This engine that Ron has built, this is a look under the hood, so to speak, the workflow and the architecture, the different kind of data that feeds into the engine, the algorithms that are used, the scenarios that are generated, and the dashboard that is presented. There's, again, a lot to digest there. Next slide, please. Further to the idea of simultaneously modeling economic and health parameters is work that we've been doing in our group. This is a graph from our research group, which shows caseloads against unemployment. So what we were trying to do, each dot here in this graph is a sequence of public health measures applied over a number of months. So you apply a certain sequence of public health measures, and where will you end up with respect to caseload and unemployment? And that's the kind of diagram we got. What's striking about this plot, what I want to draw your attention to, is that there seems to be an optimal strategy. You see the efficient frontier that shows the lower boundary of this shape suggests that there is actually an optimal strategy for minimizing both caseloads and unemployment. Next slide, please. Now let's consider vaccines. We witnessed almost a miraculous development, an incredibly fast development of effective vaccines. Rapid deployment is certainly essential to reduce morbidity and mortality, but the science of vaccine effectiveness continues to evolve. For example, early studies demonstrated reduced hospitalizations and deaths among vaccinated individuals, and therefore priority populations correctly included those at highest risk for these outcomes, including older people and those living and working in long-term care. However, there are many other communities at high risk. This population comprises largely of people from marginalized communities, including visible minorities, those unable to work from home, in lower paying jobs, and living in crowded conditions, often in multi-generational households. Hence, the principles of equity and justice were crucial in planning a vaccine distribution strategy. Next slide, please. Brian is reporting on analysis from the Science Advisory Table that noted that 30% of cases of COVID-19, at least in Ontario, occurred in 10% of neighborhoods, and 50% of cases occurred in 20% of neighborhoods. Deaths occurred predominantly in high incidence neighborhoods. Moreover, with later knowledge that the vaccines were effective in preventing infection, attention turned towards prioritizing the populations who lived in hotspots where both transmission and disease severity were higher. So in this table, what you see is 10 different regions organized from number one, that is the leftmost column being the highest incidence of COVID infections, the right hand, the 10th column being the lowest incidence of COVID infections, and the successive vaccine efforts in each of these 10 regions. And what we found is that residents of communities with the lowest risk of SARS-CoV-2 infections were 1.5 times more likely to have received one COVID-19 vaccine compared to those in communities with the highest risk. For example, among those aged at least 80 years, vaccine coverage ranged from 50 in the low in the areas in which there was high incidence, up to more than 70% in the areas where there was low incidence. So high levels of coverage among younger adults in low-risk areas likely represented greater uptake by healthcare workers. However, the consistently lower coverage among all age groups in areas with the greatest risk suggested the presence of barriers to vaccination. Next slide, please. So as a result of that, there was a change in vaccine distribution strategy, and that is to allocate 50% of vaccines in Ontario to the 74 neighborhoods comprising the highest 2 deciles of disease over a 30-day period. And that results in 18% fewer cases of COVID-19, 14% fewer hospitalizations and ICU admissions, and 11% fewer deaths. So changing the strategy of vaccine distribution, taking into account the areas of high incidence, produced better results. As a result of the implementation of this strategy over the last few weeks, the gap has now disappeared, and we're confident that the recommended strategy was appropriate given the equity and justice related ethical principles on which the allocations were based. Next slide, please. So the equitable distribution of vaccines was also top of mind in the Indian context. These slides are from Dr. Thakur. They indicate that the national vaccination program began in mid-January 2021 in a phased and targeted manner, guided by a national expert group on vaccine administration. Vaccine distribution rather was in 3 phases, with phases 1 and 2 provided by the union government and phase 3 by state governments and private hospitals. Phase 1 was for frontline workers. I think we may be on the next slide now. Phase 1 was for frontline workers, phase 2 for those over 50 or with comorbidities, and phase 3 for people of age 18 and higher. 3 kinds of vaccines were available: Covishield, Covaxin, and Sputnik. And as of now, 142 million people have received the first dose and about 40 million are fully vaccinated. As indicated, there were and are several issues with the actual distribution that probably maybe we have time to discuss later. The goal is to reach 300 million by the end of July. In addition, India being the largest producer of vaccines in the world, the country is providing vaccines to many other countries. Okay, so that in a nutshell is the upshot of our discussion. I don't know, Arun, do we have time to show the movie or not?
You do have time, Dr.
Okay, very good. So I think, could we see the Canada movie? So this is a 60-second movie. It's going to show you the dynamics of the movement of growth versus acceleration, map it against public health measures and other things that were happening. Okay, go ahead. So bottom table, you'll see the actual daily cases. The left one is giving you the movement of the different provinces. The right-hand upper screen is showing you a blow-up of that. It's moving pretty fast, but what you should notice is that when you look at these kind of movements, there are trends that we have to observe. So you can clearly see for right now, we're in August when the cases were low. And you see on the left-hand side, all the dots are congregating near 0. Now the cases start rising in the fall, October, November, December. Slowly you start seeing one after another province move forward. This speaks to the heterogeneity of the pandemic, that it's not uniformly moving everywhere. Also, another important point that is hard to see at this rate, but if you slow it down, you'll see, is that even when cases are at a maximum, This hurricane model allows you to see that if by examining the acceleration, that actually things may be getting better. So it's not just number of cases that one has to look at, but also the acceleration that gives you an insight into what's going on. The quadrants in the upper right refer to different, the horizontal axis is growth, that is daily number of cases, and the vertical axis is acceleration. And you'll see certain patterns in the way they move in those 4 quadrants, and that is still the subject of current investigation. Okay, let's have a quick look at the India slide, India movie. So this is India's numbers as far as we were able to obtain. Again, the bottom is the caseload, and the upper left is the acceleration, growth versus acceleration, and the right is the zoom of that. You can see things are sort of going all over, but there are some trends. And you can clearly see, by the way, when the first wave ends, it's really visible. And then the start of the second wave. So now the first wave is essentially over, and we think, but unfortunately this variant 1617 has been identified. And then you start in the spring, in March, first you see Lakshadweep bouncing around, and then you see state after state starting to take off again and accelerating to really very high rates of growth and acceleration. You see, we're talking about great growth between 8 and 15%, which is huge. Again, there are cyclical patterns that are still being analyzed and still have to be understood. Okay, that's it.
Thank you very much, Dr. Murthy. That's quite a brilliant presentation. And thanks to you, thanks to Dr. Brian Schwartz, thanks to Ron Dembo, and thanks to Dr. Thakur for all your dedicated work. And some of you in Canada, you are sitting around the Premier's advisory table, and you were able to predict some of these waves coming ahead of time, and you are warning us. And that work is extremely appreciated. Now, the question to all of you, in the first wave, we thought we are seeing the people who are of elderly age, over the age of 65, were affected by COVID. But in the second and third waves, even the younger people are being affected. Is there any rationale? Why is it happening? Is it because of not social distancing, or is it because of the virus spreading through the air at a faster rate? Any contemplation?
I could give you some anecdotal stories. Like, I remember walking out before the third wave hit with my dog in a park, a famous park in Toronto, the Trinity Bellwoods Park. And it was full of young people, primarily young people, not socially distancing and not wearing masks. And if you would ask me, if you walked on any main street in Toronto, you would have found the same kind of activity. Elderly people were wearing masks and socially distancing more and under lockdown. I think they took it more seriously. They thought they'd be more affected. So that's perhaps an indication.
If I can add, I think the third wave was particularly difficult because, number one, the second wave never really resolved. It never went back to baseline. And secondly, we were watching very closely the B117 variant from the UK and calculated that it was about 1.4 times as transmissible as 1.5 times as transmissible as the Wuhan variant, the original one from wave 1 and the beginning of wave 2. Secondly, it was more severe. And thirdly, it had a higher mortality. And we could watch that variant taking hold in Ontario and predict. Our models did a very good job in predicting the number of cases based on that increased transmissibility, very similar to what they saw in the UK. The public health measures lagged behind, and hence we saw the the few weeks in April where we hit close to 5,000 cases a day. And we're still seeing, of course, the effects in hospitalizations and intensive care unit admissions, which fortunately is coming down with the vaccine and with some degree of higher public health measures.
But Arun, if I could just also
Yeah.
reinforce what Ron was saying, the Fields Institute did a survey to ask people whether they felt public health measures were important. And we found we analyzed the results based on age, on various gender, various kind of factors. But we did find those in the younger age group didn't feel it was so important. That was a consistent finding. There is some scientific basis even, I think, to Ron's anecdotal comment.
Thank you very much, all of you. Dr. Thakur, you have got any comments before I move on?
Yes, so as far as India is concerned, I think we were quite comfortable with the first wave. We could take care of that very nicely. And there was, these younger people, they were not following this COVID appropriate behavior. And in fact, the infection is now going to the younger population. That is the trend which we have seen. And this second wave was really difficult for the country, and you have seen. But I think the government and the state governments, they are fighting this battle, and hopefully. But this third wave is going to be difficult. And what is being predicted, and I think I don't know whether Dr. Murthy has any prediction on that account, that it may go to the children. And a country of the size of India, if this third wave goes to the children, we may face a very difficult situation. And of course, since we have a large population, and although we are one of the big producer of the vaccine also, but to cover such a large population require time, and that is also an important issue.
So I don't know if I could just add in this that what we found and we've started to say repeatedly in Ontario, but I think the message holds good anywhere in the world and also in India. It's really a race now between vaccines and public health measures. These are the only tools we have to control the spread. It's been repeatedly stated that this virus doesn't have legs. It can't walk by itself. It doesn't spread it needs to be transmitted. It needs a human host, and it needs to transmit it. And so even while we wait for vaccines, if wearing a mask and physical distancing essentially significantly reduces the transmission probability. And so that's the tool that's in all of our hands, whether we're a young person or an old person, and that tool is in our hands now. And that I wonder, I'll say very, very significant effort, I think, has to be made to communicate that in whatever form is appropriate. If you're talking to people in a rural setting, or if you're talking to people in an urban setting, or young or old, that message has to, some effort has to be made in crafting that message in such a way that it resonates with people, that now is really a critical time. And if we can do it, then the promise is that we'll be able to bring this under control sooner than we think.
Well, that begs the question of, how you manage that lack of compliance. And just like seatbelts, when they were first instituted in cars, had a very small pickup, something like 15%. Now you can't get into a car without wearing a seatbelt, and everyone just naturally puts it on. We need that same kind of movement for masks, and that I think would have more effect than almost anything we could think of. So guess what? Seatbelts are policed. If you're riding in your car without a seatbelt, you can get a fine. And so I don't think this will happen naturally. It'll happen if we actually police it.
So that's an open discussion. I think I know around your point.
No, it's a very difficult discussion.
And that kind of conversation is taking place here as well. And I think it'll have to happen all over the world. I much prefer people voluntarily doing it by understanding that they stand to gain by something and putting more effort in education and messaging that shows how much an individual has to gain, and maybe even offering financial incentives rather than punitive approach. But I appreciate that there is the argument that's being made and that there's something to discuss there.
Dr. Dembo, your analogy is perfectly correct. Initially, when the seat belts became mandatory, until then there's lots of resistance in most countries. And only very recently, in the last 40 years or so, it became a mandatory. Before that, people were resisting. And the same goes in Canada too. While you people from the advanced knowledge and you're able to predict and all, and so on, and advising people to stay at home to avoid the spread of COVID, people are demanding. People are saying, you are curtailing our freedom. I think we all need to take, not the governments alone, but the public, the citizens, we all should take the responsibility. Imagine if it is a war. During World War, are we willing to risk ourselves to go outside? And this is another kind of war that we are facing now. There's a biological war.
There's a nice analogy with seat belts. The thing that got seat belts accepted is not messages like, as a kid, I remember pictures of beautiful women with lovely kids getting their heads chopped off because they weren't wearing seatbelts, graphic stuff. What really got seatbelts to be worn was when the messaging turned around, not like you should wear a seatbelt, but little Johnny in the back will fly through that window if you have an accident and he'll die. And so you better put seatbelts on little Johnny. And little Johnny then, and I was one of those little guys, beat up on their parents to say you should be wearing seatbelts. And in fact, my mother did hit her head on a windscreen because she refused to wear one. And after that, I guess she wore one. But it's an interesting thing. There's a lot of studies on this. But one way or another, we need to get people to wear masks.
Thank you for that insight, Ron. I just want to remind our audience too that there are two other parallel sessions are going on. And there we are talking about artificial intelligence and biotechnology. In this session on pandemic response and initiatives, we talked quite a bit about the vaccines or the biotechnology's effect. But Dr. Murthy, you showed quite a number of nice graphs and even the movie predicting the future and how much of artificial intelligence is going into it in any of your predictions.
Well, being a mathematician, I prefer not to use artificial intelligence. So I prefer to rely on the mathematical model. The hurricane model is the closest we come to using something that might be an ML type of model, because it draws on worldwide trajectories to sort of predict how the possible paths that could be taken. So that one is used, and in some sense that is what we don't know how to do though with that model, as that we do know how to do with compartmental models, is how to calibrate them when you introduce an intervention. So that seems to be harder to do and that's one of the things that we're trying to figure out. But if you use those models, then if we're able to introduce that, then we're able to use kind of some sort of hybrid between what may be linked to an ML type model and a compartment model. So our group, we use more math than AI.
Great. Thank you for that insight. And if there are no further questions, and I don't see any.
Arun.
Yeah, go ahead.
Yeah, so, people are now questioning this efficacy of lockdown, especially in a country like India, where substantial population is in the unorganized sector. You mentioned something about, Dr. Murthy, about the lockdown effectiveness. Would you like to elaborate further on that?
Yeah. So again, as a mathematician, I have a certain luxury that other people may not. Namely, I just look at the mathematical model. The mathematical model says, look, this virus has a transmission probability. It has you have to have some form of contact, and when there is contact, with a certain probability, there's a transmission that occurs. So all of our models are expressed in terms of 3 parameters. How many contacts do you have in a day? What's the transmission probability? And what's the reproduction number? In other words, on average, how many people will you infect with it? And then the question is, now, if I introduce a public health measure, how do I change those numbers? That's all. The lockdown means basically in Ontario, on average, with no restrictions, I meet 12 to 15 people a day. That's the average number of contacts a person has. When there's lockdown, that number comes down to 3. In other words, you've reduced the number of people you're contacting. Suppose you also add to that masking. That means you've reduced transmission probability. So with those 2 things, you brought down 2 parameters that go into the model. So the prediction will be that there'll be fewer cases. You see? So if you had some other way of bringing those 2 down, it would have the same effect on the number of cases. So I have a little different point of view than Ron in this approach, but I agree with you about the point is that life has to go on. People have to meet each other. People have to interact with each other. So really, maybe we need to put more effort in saying, how do we have safe interactions? How is it possible that we can interact with each other but stay safe? And I think that's a lot of effort in science table. Brian can speak to that. We've been talking a lot about that. How can we do new research on ventilation to make it safer to be in private spaces with other people? These are the questions that need to be answered. I don't think we can simply say we had to react as a lockdown because we were already in the middle of a pandemic. But I think if thinking further out, those kind of things are very short-term, very crude kind of approaches. And so if you can afford to do it, and I say afford to because right now cases are still quite high, and you need to bring them down really fast. But if you had the luxury of a little bit of time, then I would say you want to evolve opening in such a way that people stay safe and transmission probability still stays low. And that's an important question for engineers. It's an important question for health experts and other people. So I think Ron wants to jump in.
Just a quick one. It's not just about reducing, it's also about coming to the right trade-off between severe economic pain, which actually causes other diseases, and actually, the lockdown actually has and lockdown plus hospital closures for the normal procedures has a tremendously negative effect. In fact, at some point that dominates the effect of the disease. So how do you balance that? It's not just about how do we reduce transmission, but how do we create the trade-off between transmission and the economy, or the social impacts.
Brian wants to jump in.
Right.
This is a very complex question, and even the word lockdown means different things to different people. There are various, is it with a curfew or without a curfew? But Ron, you talked about your childhood. During my childhood, I used to watch a lot of baseball, and there was a professional baseball player who was also a philosopher named Yogi Berra. And Yogi said something I think very profound. He said, there's a difference between theory and practice. In theory and practice are the same, but in practice, they're different. And, while doing the, figuring out what to trade off and what the higher risk activities are that people need to avoid, and drawing the distinction between, you can go to this outdoor activity, but you can't do all the socialization that goes along with it. or you can go to this religious service, but don't do all the other things that would require being reducing social distancing. Human behavior isn't programmed that way, and unfortunately, the packages of interventions that are sometimes called a lockdown seem to have been, at least certainly in Western cultures, in Western Europe, and in the UK, and certainly in Canada, it's really been either a last resort, but it's also seems to be the only group of interventions that seems to work, because human behavior is such that the more nuanced ones are difficult to follow. And it's been tough. It really has been tough, because the trade-offs have not been pleasant.
Thank you, gentlemen. That's quite a very interesting discussion. I am getting a cue that we need to close it. In the meantime, let me welcome Dr. Avril Roy. Avril, it's been a pleasure to work with you, and your contributions are tremendous, and your summary slides were presented by Dr. Farku, and you are on the front line, and maybe only one quick question, maybe you can give us a one quick answer, and you can tell us how much is it affecting on the ground by the healthcare workers, seeing patient after patient dying, especially now in the second wave in India. You're muted, is it? No? We can't hear you. Still can't hear you.
Is it better now?
Much better.
Wonderful. I do apologize for being unable to make. I got called into some other work.
I can imagine.
It's tough. This second wave is really hitting 30-year-olds, 40-year-olds, 50-year-olds very, very hard. You know, it's okay in the first wave when you had and I apologize, most people over here are elderly, but when you had 70 or 75 or 65-year-old people, I'm sorry, they're not going to make it. Their children are well settled. Their loved ones are well settled. They've got a job. Some of them are grandparents, and there's a certain level of acceptance over there. But what do you tell the mother of a 35-year-old or a 41-year-old, or what do you tell the fathers of, I know places where fathers are bringing their children to get admitted. The fathers have got vaccinated. They're doing fine. They're bringing their children in, and the children are dying. And, they're crying to you, and you're like, I wish there was more I could do or we could do. And honestly speaking, there was nothing we could do for them. And that sort of story, day in, day out, it's been almost a month and a half. And this is not just one case. You're going to do this for 20 families, 20 or even 30 families, day in, day out. And it's and you have built a relationship with these people. They're looking forward to your phone call over 24 hours for a 5-minute conversation that, I'm sorry your loved ones are getting worse. I'm sorry your loved one's getting better. Or I'm glad your loved one's getting better. And, they're like, is there any way we can meet this person? His 3 kids, one's a 5-year-old, one's a 3-year-old, maybe their kid who's in 10th grade or 12th grade about to go to college. They want to come and meet this person. They can't. And that drains. In fact, I know a lot of people are actually actively considering giving up critical care or intensive care medicine because you can't deal with it. And that's a massive loss to the system. That's 20 years of training that's just going to disappear on you. And it takes 20 years to get replacement in, and there's no replacement coming in as well. So it's very, very tough. There's no doubt about it.
Thank you, Dr. Roy. It's the whole COVID system, COVID pandemic is complicating from every aspect of life. And I just want to thank every one of you in this panel. You have been working hard for the last 8 months and bringing the best value of science to the front, and your contributions are immense. I greatly thank you. My greatest appreciation to all of you. And Dr. Farku, Dr. Ko, Dr. Kurana, Arti, Dr. Murthy, Dr. Schwartz, Dr. Dembo, Dr. Roy, Dr. Thakur. I have no words how to express my sincere thanks to you. Thank you, and together we will win. Together, I think that's it.
Thank
Thank
you, sir.
you.
Indeed.
And we are now moving back to the other session, the concluding session. Thank you. So the session is now closed.